killed my loved one? Are the risks of the vaccine so many? People clot all the time in the community. So we still have to find out whether, as Dr. Zaid said, is this a coincidence or is it causing it? Without vaccines, people were having clotting. They were going to hospitals for clotting. And don't forget, when we're doing this mass campaign with so many people, we're going to give vaccines to people who have clotting issues. And if they do have it, we're going to check. We would know before we give the vaccine. It's just that if they come to hospital or have a clotting issue, even who had been started before the vaccine, we're going to record it. And we have to now decide, was the vaccine the one that caused it? Or, so not everything that's coming out as adverse events are actually caused by the vaccine, but that in doing due diligence, we accumulate all the information of anything that's anything that goes wrong at the time we're giving vaccines or in the period just after the vaccines. It's part of what we do for every single drug that is developed. It's not new. And vaccines or in the period just after the vaccines. It's part of what we do for every single drug that is developed. It's not new. And if you look at what we get from other drugs, it's always a long list. Most times it's not causal. I don't know whether this is causal or not. But if we also look at the long list of people who have had it without any issues, there will be, we expect that there will be some side effects, but it should be minimal and in very few people. I don't think we can get any vaccine that's 100% safe, or any drug for that matter. Thank you. I just wanted to really, thank you very much. Over.
Thank you, Prof. I like the fact that you've raised something that a lot of us, even as healthcare workers, always forget, is that even sort of the simplest drugs, paracetamol, have certain side effects. As with any drug, any line of treatment, there are considerable side effects. And I think the benefits of taking this vaccine definitely outweighs getting COVID-19. So this is a call to action. Should you have the opportunity, step forward and take the vaccine. Keep yourself and keep your loved ones protected. So on that note, I'll move to Ezine. Ezine, you have quite a number of questions, but I think I'll try to merge some of them for the benefit of colleagues. I know that you have tried to put some answers on the Q&A box. I think some clarity, if you can sort of explain that slide where you talk about sort of short-term storage temperatures and long-term storage temperatures. And also, I think there's a question around if Johnson & Johnson vaccine is a one dose and can it boost the full immunity? So if you're happy to take that question before we move to the next round of questions. Over to you, Ezine.
Okay, so like I mentioned, okay, let me just do this. So like I had shared earlier, we have these, we have the ones that have room temperature, which is every other thing else except the
fridge temperature.
Fridge temperature, which is everything else except, sorry, not room temperature, sorry. The fridge temperature except the genetic vaccines, they are the ones that need extreme cold chain. So these are for sort of like 3, 4, 5, 6 months storage. You can store them at fridge temperature. But if you want to, like Dr. Shade talked about, if you want to store it extensively for like 2 years or long-term storage like that, you need to really now do cold chain, like really cold chain of maybe like minus 20 degrees Celsius for these normal fridge temperature vaccines so that they can stay viable for that long period of time. So if it's something more than 6 months, 9 months, you need to really do minus 20 degrees centigrade Celsius for these normal fridge temperature ones. But then if you're doing vaccination campaigns, I saw that question, when you're doing vaccination campaigns, of course, we don't have things that, unless you're storing in liquid nitrogen. But if you're in the field doing vaccination campaigns and you're using the Pfizer or Moderna, these can actually be at the fridge temperature. You can use ice boxes or those cooler boxes that we use for the normal vaccinations for them, because they can stay at those fridge temperature for at least 5 days for the Pfizer and even up to 1 month for the Moderna. So that sort of like explains that. So those for fridge temperature, it's fine if for about 6 months, but long term, you need to do at least -20. But those who actually need extreme freezing, if you're going to do vaccination campaigns, they can stay at fridge temperature for some days while you do your campaigns in the field, where definitely we may not have those facilities for extreme cold chain. And then, yes, Johnson & Johnson is just 1 dose. That's the only vaccine that is 1 dose. But right now, they are conducting clinical trials to see if the efficacy can be boosted if they make it 2 doses. But at 1 dose, it has even a very significant efficacy of 85%. So that is even really good as a single dose. But they're trying to see how they can boost these just if they double the dose, if it's going to give us a better efficacy. But then there are other, like the AstraZeneca is trying to work with Sputnik to see if they can boost their efficacy with if you take 1 dose of AstraZeneca and the second one is the Sputnik V. So we're not done with vaccines yet. Even these ones that we have results for are still trying to look for ways they can boost the efficacy or be able to still be efficacious against these new variants that are coming out. So it's a continuous work in progress over one day. I think I've answered both questions.
Thanks so much, Ezine, for that. Thank you. Colleagues, please keep your questions coming. Today, we knew that we would get a lot of questions. So as you can see, we have dedicated quite a good amount of time to answer some of these questions. This is going to be a bit of open. I would really want all the colleagues on the panel to let me know if they would like to answer this question. But apparently, it looks like a few of our colleagues are concerned, and I'm seeing questions around: can a COVID-19 positive patient take the vaccine? The other variations of the question is if it's asymptomatic COVID-19 versus symptomatic, are they eligible to take the vaccine? So I think I will start off with Prof, if you'd like to answer that, and I move to Elizabeth just to get a good mix of the answers. Over to you, Prof.
Question. Sorry. Can you please repeat the question? I didn't catch it.
Sure. No worries about that. I said that I'm seeing a number of variations of this question around: can a COVID-19 patient is the COVID-19 positive patient eligible to take the COVID-19 vaccines? And there are variations to the questions around if the person is symptomatic, asymptomatic, and things like that. So I really would like us to touch a bit on that during this discussion. Over to you.
Thank you. I think what I would say is that if a patient is symptomatic, you shouldn't take it, not because there's necessarily anything wrong with the vaccine, but that's not the time to go in and one, you're likely to you're increasing the risk of those at the center. 2, your body is already reacting to the virus. So bringing a vaccine at that time is not, it's just chaotic. So I would say no. But if you've had it before and you're no longer symptomatic, and that was your first infection, there's no harm done, because then it could just be a boost to your immune system. Because if you now get it again, it's like your body says, oh, I've seen this before. And then it's almost like doing I'm just using general principles. Then it's like a boost. So, but while you're ill, I think that's a little, I don't have the scientific anything. I'm not the biggest immunologist in the world, but I think at that time, from an infection prevention control point of view, 1, your body's already fighting it. So the vaccine at that time, I don't think is of much value. It would be better if after you've had it, sometime later down the line, you take another one, then that can act as a boost to the first one that was an infection. So it's almost like the infection is a vaccination going on, if you get what I mean. Your body's immune system is already reacting. So why, I don't see the value of another vaccine, of the vaccine doing that, because what the vaccine tends to do is mimic an infection. So you already have the real thing going on. There's no need to have a vaccine going on at that same time. It doesn't add value. Thank you. That's my take on it.
And this is Elizabeth from CDC. I fully support Prof in that. First of all, if you're symptomatic, we don't even want you in a vaccine clinic or standing in line or anything like that, or potentially exposing other people who are in line with you, exposing the healthcare worker who is giving you the vaccine. So that's one thing. If someone's symptomatic, we actually don't want them, near a healthcare worker to get a vaccine. Second thing is it may end up being a bit of a wasted vaccine because your body is already making an immune response at the time, due to natural infection instead of getting instead of getting it from the vaccine. But there is a lot of evidence out there. I'm going to say a lot of evidence. There is evidence out there, though, that people who have had natural immunity, that people that have vaccine may actually have a more robust or a stronger antibody response than people who have had vaccine. So at least here in the US, we say that after somebody has had a COVID infection, they should hold off on getting vaccine for about up to 90 days. And then after that, they only need one single dose of vaccine. If it's a 2-dose, vaccine regimen, they only need one single dose, essentially as a booster. And that in that way, they will essentially be getting 2 doses overall, one through natural immunity and one through a follow-up vaccine. But that follow-up vaccine would actually come several months down the line after they have fully recovered. Over.
Thank you.
Thanks, Prof, and thanks, Elizabeth, for the very useful answers to this. That actually covers almost 6 questions that have been posted in the Q&A box. So I think that's very helpful. Prof, a few questions to you, because I think you mentioned this in your presentation. One is, what is the reason why the baby must face the mother during vaccination? And the second is, what are the reasons for the exclusion criteria that you mentioned? So if you can answer that before we move to the next questions. Over to you, Prof.
Okay, thank you very much. If you remember, one of the reasons you don't want someone who's symptomatic to come into this is so that you don't put the healthcare worker at risk. Now, we generally don't have babies wearing masks. We don't have a lot of evidence about their spreading the infection, but it can happen because they can get the infection and it can spread or can be transmitted through them. So if they are being held by their mother, they should face their mother because they already live in a cocoon with her. So, but rather than face the healthcare worker, in which case they're breathing and maybe crying into the face of the healthcare worker. So it's to protect the healthcare worker. That's why.
Thank you very much for that. Thank you very much for that useful response. Colleagues, please keep your questions coming. Isn't this is I think this question would be for you. It's what are the considerations, or are there any necessary or appropriate logistics for vaccines in the African context? I don't know if you want to touch a bit about it. I know that many countries already have routine vaccination sort of supply chains and mechanisms, and which they are co-opting for the COVID-19 vaccinations. But if you would like to touch a bit on that, over to you, Ezine.
Okay, so like you mentioned, you're very right. Countries, this is not the best vaccination campaign that countries have been doing. Some countries have done even big responses for Ebola, for polio, for the routine vaccinations we all have. So there are already systems in place. And before a country places a request, they have to do some sort of assessments on their own to say what we have in the country, which vaccine is most suitable for us. Do we have minus 20, minus 80 degree fridges? So if we do, where do we have them? Where can we use? So those are the things that influence which vaccine, based on logistics, which vaccines they can bring into the country. So it's not just we close our eyes and pick one vaccine. They have to do an assessment to make sure that when these vaccines come, we are able to administer them and they are able to keep them viable. We're able to transport them to the different locations and they still stay viable and we can give them appropriately. So these are decisions that are taken before countries decide. So there is even a question around why are countries using more than one vaccine? Why are they using two vaccines? So you've done your assessments and you've decided these are the two that will work for you based on how your systems or what's obtainable where you are in your country. And you've decided that these are the ones that will work best for you, so you get good. And you're also looking at cost as well. So those are the issues that go into those discussions. So logistics plays a big part because you need to make sure that the vaccine, from when you get it to when it gets to the person's skin system, it's kept viable. And it doesn't go and it doesn't get spoiled or become not viable by that time. So logistics plays a key part, and this is done by country to country basis. Over.
Thanks a lot, Izine, for that. I did see a question that I was going to pose up to you, but I can't find it. So I'm going to move to the next one that I can see right in my eyesight. To my colleagues on the call, I know that there have been concerns around the new variant and variants of concerns that we are seeing across several countries, Brazil, the United Kingdom, and South Africa, and I believe very recently Philippines, if I'm correct. So I think this question is around efficacy of the vaccine for some of these variants of concern. I know that several countries have reconsidered sort of their strategy or the particular vaccines they would be using based on this. So the floor is open to any of my panelists who would like to take a stab at this before we move to the next round. Prof, do you want to take it up, isn't it?
I actually didn't hear. I was busy typing answers into the Q&A. I didn't.
No
sorry.
worries. I'm happy to repeat. It's just around efficacy of vaccines for the variants of concern. So I really like this to be like an open response from the panelists. So Basim, Elizabeth, Prof, feel free to jump in.
I don't have I can't remember. I can't remember everything, but I do know that some of the variants are showing some impact on the vaccines. And I think the South African variant was one of them. And that's why, and I think it has an impact on the AstraZeneca, if I'm right. I'm not sure. I can't remember for sure. So let me not mention any particular one. But it seems to be sensitive to the Johnson & Johnson, and that's probably why the South Africans are using the Johnson & Johnson vaccine. I think there's another one from Brazil that seems to have some impact, but I don't have the details at my fingertips right now. I don't know if Elizabeth or somebody from Afro or CDC want to answer those.
Yeah, thanks, Prof. I'm not an immunologist and definitely do not want to say the wrong thing about which vaccine might or might not be useful against which variant. That being said, though, I am glad that somebody's brought up these variants of concern, because I think it means that even though we have vaccine on the continent, we still have to double down on all the basic measures. You know, that vaccine is not the be all and end all right now. It still has to get to the basic measures of social distancing, of wearing masks, making sure that you're wearing the proper mask. You know, a single layer of cloth mask is good, but you can do better. You can have 2 layers of cloth, or even 3 layers of cloth or 2 layers of cloth with a filter in between. And we need to make sure we're doing our hand washing with all of these variants of concern, because some of them do seem to have a higher mortality rate, and they seem to be more easily transmitted. And in that case, we really have to get back to what we've been saying for the past year, and get back to all the tried and true measures of trying to stop the spread of this virus while we're still trying to figure out the vaccine issues. Over.
Just to add on to that, for sure, some of these variants are showing that that they are less responsive to the vaccine, but there's no variant yet that is totally, that totally eludes the vaccines. But if they're already showing that, the assumption is that over time we may get more changes that can make them less responsive. So as Elizabeth said, we still need to do this. The good thing is severe disease will be averted, but it doesn't mean you can't catch COVID. So I think for now, we should please just continue, and in addition, continue to monitor the variants. There's a lot of work to do. It's a very new virus. I mean, I just want to remind all of us that we've gone a long way. This is just a year plus since COVID-19 hit the scenes. It feels like 20 years, but so much has been achieved, and there is a lot to, that I think that we need to load the scientific community about. So much has been done and so much achieved, but there's still work to be done. And I know people are getting tired. I mean, in Nigeria, it's very hard to believe that there's COVID-19. I mean, a lot of people just don't wear their masks anymore. But we keep continuing to encourage them.
Fantastic.
A couple of things in the area of the vaccine, saying that when these vaccines were being developed, we didn't have the variants. I mean, we haven't yet discovered these new variants. And so the early vaccines like the Pfizer, the Moderna, really weren't tried. The clinical trials did not include people or include the new variants population. So now they're going back to look at how to see if it's effective. There are now clinical trials just targeted at the new variants. Even the same issue with AstraZeneca. So they had to do clinical trials again to check if it's responsive to the new variant. And now they're actually, based on their feedback, trying to work on the vaccine again to develop a jab that is specific to these new variants, and they can have better efficacy against the new variant. So like Prof said, it's still a work in progress. We're just 1 year and we've discovered 3, 4, 5 key new variants, and that means we'll keep discovering. And the vaccine, it's what viruses do, they mutate. So we keep discovering, and these vaccine companies and even the newer vaccines that are coming up will now take these new variants into consideration when they're doing clinical trials, when they're developing the vaccines and all. So it's a continuous thing. And of course, countries are now doing genomic sequencing to be sure. It's part of that assessment they do before they decide which vaccine they will pick, to know which variants is more where they are. Is the vaccine you're deciding on going to be efficacious or effective against this variant? So genomic sequencing has become part of the routine surveillance that most countries are doing, even in Africa, and that helps countries also to make the decision as to vis-a-vis variants of concern. Does this vaccine work for us or not? Over.
Thanks, Ezine. So I think one final question just before we go, and before we wrap up, I'll also give all the panelists an opportunity to say just one line if you can. So start thinking about it. If you had to advocate or say anything about vaccines, I think it's important that we leave our participants with a resounding message around COVID-19 vaccination and how to keep ourselves safe. So I'll come back to that. But I will throw this question because I just saw Prof. Valerie now. It's around IPC, again, going back to vaccinations. IPC approach for vaccinations with Ebola and COVID. Are they the same or different? And if they're the same, does this mean that countries that have experienced Ebola in the past have some sort of advantage? I think we just need to reemphasize sort of the necessary IPC approaches for vaccination against Ebola and COVID-19. Over to you, Prof.
Okay, so I'm from Southern Africa, so I have not worked in West Africa. But we have to remember our IPC practices are based on the mode of transmission of a pathogen. So when we're talking about COVID-19, we're talking about respiratory transmission, droplet transmission, and contact transmission. When we're talking about Ebola, we're talking about contact transmission. So the type of PPE you need for COVID-19 is not as extensive as you need for Ebola. So the approach is different, but if you consider basic IPC principles based on transmission, then you come up with the correct solution. And Prof. Ogunzola talked about the PPE requirements for COVID-19 very clearly. And I think you didn't hear any mention of hazmat suits at all in her presentation. And I think that perhaps describes the difference between the two.
Thanks a lot, Prof. Val. That's very useful. It's good for us to also remember that, the PPE required for both infections. So on that note, I think we've had an exciting Q&A session. It's been quite eye-opening, and I would like to hand over to Prof. If you could say one thing to our colleagues on the line about vaccination, what would it be? And right after Elizabeth, Ezine, Prof. Val, and Zaid. Over to you, Prof.
Thank you. Let me remind everybody that the fact that these vaccines came out early does not mean that there was a shortcut in terms of checking them for safety. One of the things we must realize is that COVID-19 is so infectious. There were lots of people that we could test, so that they could carry out their tests in a much shorter time and get the numbers very quickly. At the end of the day, there's no perfect solution, but the vaccines are generally safe. There will be some with side effects in people, but I would advise everybody, please do go take your vaccines. Most people that have taken these vaccines, and I mean the overwhelming majority, have not had any major side effects, just a few inflammatory things and pain at the site. And those are things that we're used to. Thank you.
Thanks, Prof. Elizabeth?
Sure. For me, I think of two things, one of which is I would much rather deal with a side effect of vaccine than I would want to deal with actually being infected with COVID. You know, if I look at my two choices, I think the vaccine is clearly the better way to go. The second is vaccines have been proven time and again critical and important and fundamental to the way that societies can flourish and improve. And we just have to look at how smallpox has been eradicated, how polio has been largely controlled, how measles can be controlled with good vaccines. Think about all the childhood diseases that have largely been controlled, not 100%, but largely been controlled with vaccines. And I think we need I think the big difference with this is that suddenly we're saying that all adults should get vaccine, but we're used to saying all children should get vaccine and all children should get multiple vaccines. I think it's time for all of us as adults to also step up and also get vaccines to try to get rid of this bug in the world. Over.
Is it my
Isn't it?
turn?
Yeah.
So as soon as I am eligible for a vaccine, and in Zimbabwe, where, as you saw, vaccinating healthcare workers, frontline workers, as soon as I'm eligible, I will be there to get my Sinopharm shot. I recommend everyone else does as well, gets vaccinated.
Thank you. Isn't it?
Everyone has said it all, just in case anyone is still sitting on the fence as a healthcare worker, because actually a lot of healthcare workers are very hesitant, even with all the knowledge we have. But it's understandable. This is all new to us. But just in case you're still sitting on the fence, I really hope all the conversation we've had today, very sincere, candid conversation, has helped a bit to help you edge towards whenever you're available or whenever the vaccine is available where you are, that you take the vaccine, because I will, once it gets to where I am, definitely take the vaccine. Over.
Thank you. Basim?
Yes, in my opinion, I think let's get the vaccine. The best COVID-19 vaccine I would recommend is the one available to you. There isn't much, in my opinion, there isn't much significant differences between the different types of available registered vaccines, COVID-19 vaccines. So the best one is the one available to you. This is number one. Number two, it will take time, unfortunately. We would appreciate if we could have a huge number of vaccines available by now, but it may take time for majority of people to get vaccinated. So we still need to continue, unfortunately, or fortunately, depends on how you see it. We still need to continue practicing the COVID-19 protection bundle, if you will. We need still to continue with the masks and distance, and physical distancing and hand hygiene and other protective measures while we are in crowded places. And also we have to monitor and we have to protect ourselves. We have to still conduct screening and triaging in healthcare facilities and in the public places and public buildings as well. Unfortunately, this may take some time, as being said by other colleagues, till we reach a critical point or a threshold where this virus will find less susceptible people in the community being vaccinated, so that it can slow its transmission. But on the other hand, compared to other outbreaks and pandemics, this is really quick and fast. The response of the 21st century is significantly better, in my opinion, compared to other outbreaks and pandemics that the world witnessed over the last centuries. So we keep to be optimistic, take the vaccine, still continue and taking the protective measures till the immunity build up in our community, and we combat together this virus and this pandemic. Over to you.
Thank you, everyone. We've gone a few minutes over time, but we can all agree that it's been such an interesting discussion. I wish we could continue, but we would need to drop off now. I will leave you with just a few messages. Go get the vaccine. When you do, as healthcare workers, we are sort of the examples the community look up to. Put it everywhere, show people that it's safe and it's effective. Make sure you tag us on social media when you do collect your vaccine. But in the time being, maintain physical distance, keep your face mask on, and keep your hands clean, washing them or using alcohol-based hand rubs. Thank you very much to my very amazing panelists. This was so exciting. Thank you so much. And thank you to everyone for joining in. On that note, I say bye-bye and have a lovely, lovely week. We'll see you next week. Bye.
Bye-bye.
Bye. Thank you.
you.